από την εταιρεία Ένθεσης για το laser ablation. Dear colleagues, in the next 30 minutes, we're going to discuss about laser technology in AF ablation. This is a satellite lecture that is sponsored by Enthesis. Enthesis is the commercial representative of Cardiofocus, the company producing laser technology. And I have the great pleasure to introduce Dr. Peter Koopman from Heart Centrum, Zesa Hospital in Belgium, who's gonna share with us his experience in laser endoscopic ablation in atrial fibrillation ablation. Peter, your title says that it's laser technology is a new weapon in our arsenal, but actually laser technology is not that new because it has been used for several years before. Of course, in Greece, we don't have so much experience, and if you have a new option in performing AF ablation, you can consider it as new. So we usually differentiate ablation techniques as the conventional point-by-point ablation and one-shot ablation. So we can categorize laser ablation as one-shot ablation, but probably we can do a more customized approach in PV or in PVI. And the question is if we can do a wider PVI or if we can intervene in other areas of left atrium other than the PVs with laser. So I'm sure that you will answer all these questions. Afterwards, we're going to discuss this with my co-chair, Dr. Katsaras, which is my colleague. We are working in ESO Hospital. So, Peter, we intend to seize everything you say.
Now, thank you very much, Mr. Chairman, for this kind introduction. I'm very sorry I will be giving this talk in English because I studied 2 years of Greek, but it was not sufficient to do this talk in Greek. So because this is a lunch presentation, I also brought some famous foods from Belgium. As you can see, the French fries, they're actually Belgian fries. Waffles, chocolate, chicory, Brussels sprouts, asparagus, and the very sweet Ghent cuberdons. So this is your meal for today. But I was effectively asked to talk to you about laser endoscopic ablation, and the organizers chose the title, A New Weapon. And I must say I'm not very happy with the new, but I'm not very happy with the weapon either. But I will try to show you in the next of my talk. Now, if we think of weapons nowadays, this is the word that comes to mind in the Ukraine. Of course, this is not what we will be talking about, but if you want to compare ablation techniques to weapons, then this would be our traditional RF ablation. It would like be the gun of a very skilled cowboy, and if he's skilled enough, he will be able to shoot the targets, but the lesions will be scattered a little around. Now, laser balloon ablation, you would compare to this very smart laser gun, which has also an additional camera, so you can see everything much better, and you can very precisely wipe out the targets, the specific targets that you want. If you would compare this to cryo balloon, that would be like a bomber. You release a lot of energy in a certain space, and you hope that everything will do the trick. And if you would compare it to pulse field ablation, it would be like this nuclear bomb. It would create a very huge shockwave. It will effectively wipe out everything. But the question is it this what we want? And of course, it's not new. We performed our first laser ablation in Belgium already in 2014, and even then it was available for a couple of years. And since then, lots of reports have been published And here you see some studies from literature, which are effectively all showing the same, that laser balloon and RF ablation, or laser balloon versus cryoablation, the techniques are both as effective. You have around 70 to 80% of AF-free survival at 1 year. But that is talking about effectiveness. And what we want in our lab is not only effectiveness, it is efficiency. And efficiency is so much more. It's also low amount of complications, it's also high speeds, and it is low costs. And if you can combine this all, then you have an efficient technique. And so I will be trying to show you that the laser balloon is one of the most efficient techniques that's around at the moment. Now, for the ones who do not like me talking, you can just sit back and relax and watch the video that I compiled for you at the left upper hand of the screen. It's showing you our first generation laser ablation. That's as we did in 2014. It's effectively some kind of point by point ablation, segment by segment ablation. It will be going around the vein here, as you see. And in the meantime, I will be talking a little about the technique that we will perform with the cardiofocus laser balloon. Now, first of all, this is a flexible balloon. It has a dynamic size, so you can inflate it the way you want, and it has a soft tip, so it's atraumatic to navigate inside the left atrium, and it comes with this flexible and steerable sheath, so you can effectively reach every area inside the atrium. Now, what is interesting about this balloon is that it has a dynamic size. So this means that well, if you compare it to the cryo balloon, that's a fixed size balloon. When you put it inside the vein adapts to the balloon. And with the laser balloon, it's the other way around. It's the balloon that adapts to the vein. So you will inflate it just to the size that occludes the ostium of the vein and not go inside the vein. So this way we can tackle almost every anatomy. So for us, it's not necessary to perform a CT scan before the procedure. We just can put the patient on the table and we know we will be able to ablate all veins. Now, laser energy is also an energy that is delivered. It's a thermal energy, but it's delivered inside the tissue. So that means you do not create a burn wound on the inside of the atrium. The lesions will have less edema than the classical RF ablation. They will be very delineated and very durable, as I will show you later on in this presentation. Now, to help us, we have a camera. It's like an endoscopic vision inside of the veins. And this is the image that you can see when you inflate the balloon and you put it, or you push it at the ostium of the vein. It's like a wide band of contact between the atrial tissue and the balloon at the ostium of the vein. In the inside here, you see the blood that is pushed a little inside the vein. This is the left inferior pulmonary vein. At the top, you see the left superior pulmonary vein, or it's not occluded, of course, but you can imagine it's here. We have the camera that is superimposed on the laser. So this creates a kind of blind spot here where you cannot see through unless you pull back the laser or unless you rotate the device so another portion of the vein has the blind spot superimposed. And then you have this, this white spot here that is a visual interpretation of where the laser energy will be delivered. It will be flickering during the procedure, but laser energy is delivered constantly. So as you see with our segment by segment ablation, we have almost done an isolation of the veins here. I will also tell you that although we do not do a CT scan, we perform a rotational angio on the table when the patient is there, just to appreciate the position of the balloon, which is also very interesting during the procedure. And you have to know that this energy of the laser, you can titrate. So it's not like a cryo, you freeze everything at the same temperature. You can deliver lower energies at the posterior wall or higher energies at the anterior wall of the veins that you are ablating. So I think here we have a very nice technique, and this shows also in the results we have from this first generation laser balloon ablation. As you can see here in this Kaplan-Meier curve, we had like 88% of AF-free survival at 1 year for both paroxysmal and persistent atrial fibrillation, which I think shows us that we chose a very nice group of persistent patients and not the very difficult ones. And even at the 5-year survival here, because it's really a long time we are using it, we still have almost 80% of patients that are AF-free for the paroxysmal group and more than 65% in the persistent group. Now, this kind of procedure was not really fast. It took us around 129 minutes for a procedure with 50 minutes of fluoro time. But when we did redo procedures, we saw that most of the veins were isolated, 62%, and in AT, all pulmonary veins were always isolated. Now, with these results, our first generation laser balloon ablation, we were on the bright side of this curve here. You see different centers that report their 1-year success of laser balloon ablation. But what is interesting with our 5 years results, we are still very well. And I'm not showing you this slide because I think we are very good. I'm showing you this slide because you can see that during these 5 years, most of the patients stayed AF-free and very few patients came back for a redo procedure. So this means that the lesions we are creating are effectively very durable. Now, since 2014, a lot has happened, and in May 2019, we started doing ablations with the 3rd generation of this laser balloon, which we call X3. Now, X3 had 2 innovations. First of all, it had a new balloon, which was called the Excalibur balloon. The Excalibur balloon was more flexible. So when you push it at the ostium of the vein, it's the balloon that will deform. And so you can create a better 360-degree view around the ostium than with the 1st generation. And as the 3rd generation arrived, we had also a motor inside the handle that allows for automatic circumferential ablation. So the laser beam goes around by itself in a continuous fashion, so we can create a continuous circumferential lesion. So now this laser device has the best of 2 worlds. It has the best of RF, and it's a really flexible tool, and you have choices, and you can choose where you ablate, and you can also see where you ablate. So that's very nice. And it also has the best of cryo, which is it's fast. And I will show you this in the results of our X3. Again, I have compiled the video for you. Now it's not sped up, it is real time. So I only have 3 minutes to talk on this slide because the laser beam will effectively go around this vein in 3 minutes, and you only have to steer it and stay on the white tissue and not on the black pool of blood. You see I'll first go underneath the blind spot. So this gives you some time to appreciate these figures I have here. These are our first 50 X3 procedures, and these are our 50 last Excalibur procedures. And as you can see here, the time to treat a vein has halved just by using X3 with the same results. And as we are using X3 more and get more experience, you can see that procedure times are still going down. With the last 50 procedures, we are now at a median of less than 1 hour with a fluoro time of only 6 minutes. So it does what it advertises. It's really fast. Now, as you see with the growing number of cases here, I propose to you the figures of 296 X3 cases. We did more of them, but these are the ones that we have long-term results of more than 1 year. You see that procedure time has gone down, fluoro time has gone down, and it is still going down as we speak. So even now we are still learning how to ablate better. But these are interesting figures. Look at this. Acute PV isolation, 98%, and first pass isolation, it's an incredible 96% with X3. So that means if you go around the vein just once with this device, you can call it single shot or single sweep if you want, then you have isolated 96% of pulmonary veins. Our recurrence is not so interesting, but look at this. This is a proportion of patients that come back with recurrence of atrial arrhythmia. And in only 30% of them, we have PV reconnections, and 70% of those patients did not show PV reconnection. So again, these are very durable lesions, even with this X3 device that goes around very fast. And these are our 2-year results. As you can see here, we have almost the same results as with the first generation of laser balloon ablation. We have 86% of success at 1 year for paroxysmal and almost 80% for persistent atrial fibrillation. Now, this lower number shows you that now we are accepting also more difficult persistent patients. At 2 years, still more than 80% is AF-free in the paroxysmal group. So again, this shows to be a very promising technique. And if I put these 1-year results back on the graph you saw earlier, we are still at this very bright side of the line freedom of arrhythmia. And we are not the only center that has these results. look at the X3 pivotal study that came out. This is a combination of patients from Frankfurt, Boris Schmidt's lab, and Prague from Peter Neusel. And as you can see here, this was the historical cohort of 170 first-generation laser patients. They had quite long procedure times, long ablation times. With X3, procedure time more than halved, ablation time halved, fluoro time went down tremendously, and the chronic effectiveness of these lesions at 1 year went up a lot. And this is exactly the same as we saw with our ablations, procedure times halved, fluoro times halved, and for us, chronic effectiveness stayed almost the same. Now, you have to note that in the pivotal study, they had a 30-minute waiting time, which we didn't have. So you can see that this procedure time is almost exactly the same. And this is what we see a lot with centers that start with laser balloon ablation. And if you are an experienced user or you are just a beginning user, you will get these low procedure times no matter what. Here I will show you two images of a redo procedure of a patient that came back with a recurrence of atrial fibrillation. And this is typically the atrium that we see then. All four veins are isolated, and sometimes there is some atrial substrate, but with a laser balloon ablation, we prepare for this situation and we prepare for a substrate ablation when necessary. Most of the times we will not see a gap. And I can show you our results in this adapted graph. This was from the ablation index close protocol from Matthias Deutschaver's group, which showed you that even up until now with RF, with second generation cryoballoon, when you go back for a redo ablation, most of the times the pulmonary veins will show reconnections. If you perform ablation with RF and the CARTO close protocol, then you could achieve like 62% of patients that come back and do not have pulmonary vein reconnections. And with our laser ablation, we can easily match this figure and even go beyond it. So you see that with the first generation laser, we already had 70% of patients that have all veins isolated, and it's exactly the same with the third generation laser balloon. We have 70% or more of patients that have all veins isolated during a redo procedure. Now, laser balloon ablations also changed the workflow in our lab. As you can see here, I show you the last 50 cases we performed with RF ablation, and the last 50 cases we did with laser balloon ablation, and you appreciate that there's a huge difference and also less dispersion in time during these two procedures, average procedure time. So we perform like 90 minutes on average with CARTO and 60 minutes with laser. So that means that we do not put in urinary catheter anymore, especially because we don't give extra fluids with the laser balloon ablation. And we also have much less tamponates with the laser balloon than we have with classical techniques. And this means that we do not do arterial pressure monitoring anymore. So this again saves us time, not only during the procedure, but also in the preparation of the procedure. So this means if you look at the workflow in our lab, that prior to 2014, when we started with laser balloon ablation, we did 2 RF ablations of atrial fibrillation a day, and maybe something small afterwards, like a flutter. I have to say that since 2019, we can do 3 with the new techniques, but with the laser balloon, we already had this since 2014, that we could perform 3 ablations a day. And you see, we only work until 4, and then we have to clean up. Now, since X3 came, our efficiency went up and we were able to perform 4 AF ablations a day, just until 4 o'clock. And since this year, now we have gained a little more experience with X3, you can see that I can now perform 5 laser balloon ablations a day. So this is a huge difference if you look at the progression we could make in the past 5 to 10 years. Since the procedure is shorter, the patients have almost no side effects of this procedure, they do not experience pain afterwards. And they do not have an arterial line. We started to discharge almost all of our patients the same day. So now we are now performing almost all PVIs as a single day discharge procedure. Now, I'm already at my conclusion of this talk. I think the success of our X3 laser balloon device in Hasselt is due to several factors. First of all, the use of 3D rotational angiography. So I said I do not do a CT scan, but I do a low dose 3D rotational on the table. And this gives me much more confidence in the positioning of my balloon. I can much more easily steer the balloon around in the atrium. I can use less fluoroscopy. So for me, this is a nice thing to have, but it's not obligatory. but it helps in balloon positioning. And that is the second thing, the second factor of success. You have to position the balloon so you can create this 360-degree view. So we never, ever start an ablation when we have like this gap here where we cannot see the contact with the tissue. We adjust the positioning of the balloon until we create the image on the right. We have a nice 360-degree view. I can go around with the automatic laser beam in like 180 seconds or 3 minutes, and I know I will not have left a gap. So I will not have a reconnection when this patient comes back. And the third factor is, of course, operator experience. So I always tell people that it's a very easy procedure to learn. Once you know how to position a balloon, if you can already do it with cryo, you can very easily go forward with this laser balloon. But the more experience you gain, the easier it will go and the better results you will have. So in our center, we have almost 1,000 laser procedures as we speak, and almost 500 X3 procedures. And this shows, because we are 2 operators, and one of the operators in our center is performing 3 times as many X3 procedures as the other one. And as you can see here in this table, you see that for the more experienced operator, procedure times are lower, fluoro times are lower, acute PV isolation is higher, first pass isolation is higher. Recurrences are almost the same, which is very interesting, but as you see here, the proportion of patients that come back without PV reconnection is much higher in the more experienced operator. So I hope that in this presentation, I have shown you that the laser balloon is not only effective, but it's also very efficient. We can perform most of the procedures in less than 1 hour. And if your workflow is well, then you can do 4 to 5 procedures a day. And I have to note that our patients are under general anesthesia. So it's not under sedation, because then you could do even more if you want. Then secondly, you will have very good results at 1 year, but also at 5 years. And I dare you to look up results in literature for cryoballoon at 5 years. I don't think you will find many. Laser balloon, you have almost 80% still of patients that have no recurrence at 5 years. There are very few phrenic nerve palsies and very, very few tamponates in our series. And the cost of the procedure is also low. First of all, because you do not need long training for this procedure. You do not need someone who's behind the carto console and is helping you. I can perform this procedure just by myself and with 1 nurse in the lab. We have a very short learning curve, and all patients are discharged the same day. And this is also more beneficial to the patients. So I think all in all, this technique is very efficient. And I know there are many very interesting techniques that will emerge in the near future, such as pulse field ablation, which will also be very fast, of course. But I can tell you that every user of this laser balloon system has always been very happy to use it. Here you can see some Twitter reports about the laser balloon. This is my colleague David Kenigsberg, who has he was the most experienced operator in the United States. He says almost the same as me. Here you see his 100 procedure, 60 minutes skin to skin, 4 minutes of fluoro, 100% in this rapid mode going around the vein as a single shot or single sweep PVI. Henry Huang, he also performed his 80th laser case in Chicago. You can see here, he confirms that the case was elegant, effective, and fast, and he could do like a nice waka around the ostium of the vein with a visual confirmation of where he put his lesion. And this is a report of me doing a proctoring case in Ghent in Belgium, where we had the fastest procedure that I ever did. It was 30 minutes. We had 2 common veins, one at the right, one at the left. So that meant only 6 minutes of laser time and less than 25 minutes of left atrial dwelling time. So dear colleagues, ladies and gentlemen, Mr. Chairman, I think I have tried to make my point that laser balloon ablation is very efficient. It's not a weapon. It's a highly technological progression in ablation techniques. And so I hope that I can convince some people to at least try it. I think you will not be disappointed about it. Thank you very much.
Thank you, Peter. It was a very nice presentation. But you see, we are living in an era where we are waiting for new technologies like PFA, like new catheters with short power, high power, short duration. Do you think that laser technology has a future, or it might be improved in order to compete all these upcoming technologies?
That's a very good question, and people ask it to me all the time when I give these kinds of talks. I think laser balloon ablation definitely has its stand and its place in the current ablation era. As you know, pulsed field ablation, it's very hyped at the moment, but the technique is new. We still have to see what it will deliver at the longer time. As you know, we are also doing pulsed field ablations. You will wipe out a lot of the posterior wall, and I'm really not sure what will happen to those lesions. They're very huge. A large portion of the atrium has gone, and I don't know if this is the thing you want in, for example, young paroxysmal AF patients. So we have to see what the future brings. As for complications, PFA is also really hyped that you do not have any complication. I do not think that that is true. We will see our share of complications also, although the pulmonary veins and the esophagus and the phrenic nerve will be spared, of course. But as you can see in our laser cohorts, we also have very few complications, almost none, and it's become for us a very safe technique to perform. And then as to new advances in RF techniques, that is of course true, and also new advances in the cryo balloon, but none of these techniques is as precise and as visually confirmed as is the laser ablation. Moreover, the next generation of the laser balloon will come not only with this endoscopic black and white view, but with a real camera inside. It will also allow you to look behind the blind spot and a little further than just the image that you can see now. So you will also be able to see outside of the reach of the balloon. So this will make the procedure even more safe. So, and I think that everyone who has used it has seen that the technique is really more precise than any other technique that you have available on the market right now. I would like to come back to one of the disadvantages of the laser balloon, and that is that you can only use it for pulmonary vein isolation and not for other stuff, although it has been tried. I have some very skilled colleagues in Japan that try to do everything with this laser balloon. They can perform a mitral isthmus line with it. They can do a posterior wall ablation with it. So it's possible, but it's a little off-label to do so. And of course, as you know, no reports exist in literature that have shown us that doing anything more than a pulmonary vein isolation has added to the success of AFib ablation. So I still think that a first procedure should really be a very good pulmonary vein isolation, where you know you will have successful vein isolation, and then when patients come back and they have a very diseased left atrial substrate, then probably you can do something more, although it's still not sure what exactly we have to do. So it's a disadvantage that you cannot do more, but if you really want, you can. But the question is it necessary to do anything more? And personally, I don't think you should in a first procedure.
Yes, surely. It's the only technique you can really see what you burn. In all other techniques, you have a dummy of the heart, a 3D model, or the 2D fluoroscopic imaging. So Dr. Katsaras, I'm sure he wants to comment.
Hi, for me, a very comprehensive lecture. I had the privilege to get trained in UK Center alongside Dr. Gold, who was a very big fan of laser balloon technology. He has been using it since 2013.
Yeah, that's true.
So I have some technical questions for you. There was a nice paper from Professor Schmid suggesting that the recurrence rate is higher when you use lower energies, like 5.5 watts to 7 watts. And another nice publication from Gao suggesting that the left atrial wall thickness is smaller post-laser ablation as compared to RF ablation. Taking these two into consideration, do you have any experience regarding performing WACA with laser balloon? I mean, when the ostia of the right-sided veins were quite close, or the left-sided veins were quite close, since you can see your lesions actually endoscopically, so you know where you have already burned, you can create a WACA, but on many occasions you cannot deliver more than 5.5 watts in the carina. So this was when we have seen the numbers you were suggesting. We were bringing patients back for a redo procedure, and all four veins were isolated. But when they were reconnected, most of the times the reconnection was alongside the left tetraral appendage, left superior vein ridge, or the carinas.
Yeah.
And maybe this has to do with the energy. So if you
Yeah.
cannot avoid delivering 5.5 watts, can you go more antral and perform waka? Have you tried this?
Yes. So I'll first tell you about the energy. I personally never ever use 5.5, 7, or 8.5 watts anymore. If I do manual lesions, so you can also quit the rotational mode and do some manual lesions like we did before, I will always use 12 watts or 10 watts, never less. And we can do so because now the X3 balloon has a coating on it and it's resistant to perforation. And I've in all those almost 500 cases, I've never been able to perforate a balloon anymore. So the lower energies, I do not use them anymore. When you go to rotational mode, you have the choice between two energies, 13 watts and 15 watts. They seem to be higher, but that's not the case. 13 watts going around circumferentially in one rotation, it's almost the same as doing point-by-point ablation with the laser at 8.5 watts almost, and the 15 watts is the 10 watts of the manual mode. So if I do a full automatic rotation now with the laser, there's just in one sweep, I will always use 15 watts, except for the spots that I do not want to use 15 watts, and that's where the phrenic nerve is crossing, and that is where the tissue is very narrow. Then I would go to 13 watts. But otherwise, I will always use 15 watts all around. And this way, I'm always delivering the high energy. So this problem is probably solved.
Okay.
Then the thickness of the atrial tissue is due to the edema that you create when performing the ablation. And it has been shown effectively that the laser balloon ablation has less edema creation than other forms of thermal ablation. So that's a good thing. And it is true that in my experience, most of my recurrences are somewhere at the carina, anterior or posterior carina of both of the right and left veins. This is not the case for Boris Schmidt in Frankfurt, who also has a huge amount of laser ablations,
right
and he does
superior.
not see that, which I think is very strange. And I think that is because he is ablating more inside of the veins. So for the left pulmonary vein, he always has a 360-degree view, but he's still a little inside the vein. And then I think you have less problems with the carina. You can always go over the carina with high energy, and you do not see these recurrences at the carina. I have tried to solve this by still performing a wide osteal ablation. It's not really a waka that I do, but it's a wide osteal ablation with my balloon well outside of the vein. And I deliver an extra 12-watt bonus lesion on the carinas, and then I do not see these recurrences either. So you can go wider. If you inflate the balloon any further, you can really perform a waka. If you want, you can do both veins. One semi-circumferential at the superior, one semi-circumferential lesion at the inferior, and try to connect them. But Tom de Potter from Aalst in Belgium has made a report on that, and he has a lot more reconnections than you would have if you would do just vein by vein and try to do a wide osteal ablation. So that would be my recommendation.
Okay, and one more question. If you get blood ingress and you cannot avoid it, you've tried every maneuver and you still need to deliver point lesions. So you start with rapid mode and then you need to go to manual mode and then return to rapid. Do you deliver the first manual lesion on the 100% overlapping with the end of the rapid mode?
Yeah, I do.
Okay.
Yeah, I always try to, all ends you have with rapid mode, I try to do full overlap. It doesn't take you a long time if you can do it circumferentially, and it only takes you a few seconds to do full overlap. If I start manual lesions, then I also overlap. And that is because if you start or end a rotation, you have not delivered full energy at that spot, because you still need to go over it with the other half of the beam. So that's why I always start at the same site that we ended the rotation.
Do we have time for one more question from me?
Yes.
Last question from me, the vagal responses. We had noticed that you get more vagal responses ablating in the left superior, the left veins, mainly the left superior vein. So what do you recommend? Because new operators in Greece are not familiar, and what are your suggestions regarding the strategy of the procedure? Do you need to down titrate? Do you need to stop if you have a hemodynamically stable patient? What do you go more antral, more osteal?
It's interesting because I do not encounter that as much. I must say I have it a lot more with pulsed field ablation, that we have these vagal responses. With the laser, it's rare, but it happens. What I mostly do, I have a catheter inside the ventricle because I did the rotational angio, so I pace on that if it's very prolonged
And you
vagal
carry on
maneuver, and I
ablating.
do not stop. I always try not to stop. Now, I have to say that with the rotational mode, I have not seen it never ever. So I think because you do the rotation, you have less damage to the surrounding tissue also, and you keep the energy for the tissue itself. But if it should happen and I would not be able to pace, then you can always try to inflate or deflate the balloon a little and try to avoid this spot. That being said, there are some US groups that are now trying to deliberately attack these spots where you get vagal stimulation because they think that the gangrenous plexa are there, and they think the ablation will be more successful if you also wipe them out.
Okay, thank you.
So Peter, it was very interesting what we heard, and also the conversation was fruitful, answering all these details. So we have to close this session. I want to thank you for your participation. I want to thank also the company Emphasis for supporting this lecture. I want to thank you all. Thank you, and I hope that next year in our Congress we will invite you here in Greece in such a wonderful place.
That would be very nice. I'm looking forward to it. Thank you.